Hello everyone, I welcome you all to this series of lectures in rheumatology. Today we will be discussing about a very important topic which is spondyloarthropathies. So let's begin. So what do you mean by this term spondyloarthropathy? So spondyloarthropathies are a group of disorders which usually affect the joint, which is why it is called arthropathy, and spond refers to some amount of vertebral involvement as well. So, spondyloarthropathies are a group of autoimmune disorders where there is spine involvement plus joint involvement. This is the simplest way to make you understand what exactly are these spondyloarthropathies. Okay, so the very famous disorder which you will remember when you speak of spondyloarthropathies is Ankylosing spondylosis. But later on, research suggested that there are few other disorders which can be grouped together because they have a similar pathophysiological mechanism, and these group of disorders is what we call as spondyloarthropathy. So what are those disorders? So the first one is the Ankylosing spondylosis. Then what is the second disorder? The second disorder is the reactive arthritis. Reactive arthritis was previously called as Reiter's syndrome. Then what is the third disorder? The third disorder is psoriatic arthritis. And the fourth is the inflammatory bowel disease associated arthritis. So, the older name that we used to use, which is Ankylosing spondylosis, has now been grouped under spondyloarthropathies along with these disorders, which is reactive arthritis, psoriatic arthritis and IBD-associated arthritis. Clear? Okay. So, what we have to know is that there is a new classification system that has been proposed to help us understand what exactly are these spondyloarthropathies. Okay. So we know that spondyloarthropathies involve both the spine as well as the peripheral joints. But the diseases can vary in presentation. Some of them can have predominantly axial or spine involvement, and some can have predominantly a peripheral involvement. That is the reason why we classify spondyloarthropathies as axial SpA and peripheral SpA. Okay? Fine. Also, we know that ankylosing spondylosis finally results in bony ankylosis of the spine and it restricts the movement, correct? So, this bony ankylosis is usually the last stage of the disease. So, spondyloarthropathies and ankylosing spondylosis can be a spectrum of diseases which can have very minimal radiological involvement or very minimal spine involvement where there is no radiological features appreciated, or it can be a full-blown disease where you have a lot of radiological signs. So that is the reason why axial SpA, which is the new name for ankylosing spondylosis, is classified as non-radiographic and radiographic SpA. So ankylosing spondylosis is not being used now as the term. It is basically classified as axial spondyloarthropathy, and this can be further classified as non-radiologic as well as radiographic SpA. So this non-radiographic SpA can convert into radiographic SpA. That is, it continues to progress only in 5 to 10% of the individuals with spondyloarthropathies. Alright, clear? So, what do we basically take into consideration under this classification? So, the first and the most important hallmark feature for axial spondyloarthropathies is the presence of this one particular important clinical feature, which is inflammatory back pain. Okay, so it becomes very imperative for us to differentiate between what is inflammatory back pain and what is mechanical back pain, right? So there are certain important features which we call as the red flag signs for inflammatory back pain. Okay, so what are the characteristics of inflammatory back pain? First and most importantly, age less than 40 years. Age less than 40 years. So, inflammatory back pain is usually a back pain which occurs in the young. Elderly individuals may have back pain secondary to mechanical back pain, or they can have back pain secondary to fracture, secondary to trauma. So inflammatory back pain is usually the back pain in the young individuals. Then it persists for more than 3 months. The inflammatory back pain has been going on for more than 3 months. Alternating buttock pain, a very important red flag suggestive of inflammatory back pain is alternating buttock pain. Then, so this particular back pain improves with exercise, and this is a pain that lasts for more than 45 minutes. Similar to how we take history in rheumatoid arthritis, we ask whether there is morning stiffness and pain which lasts for more than 30 to 45 minutes. Early morning stiffness, yes. So this particular pain also lasts for more than 45 minutes or more than 30 to 45 minutes, and it is more so in the morning. So it is more so in the early morning. Okay, so this is also associated with early morning back pain, so much so that they can also wake up from sleep. And sometimes it can be associated with chest pain, which means that there is evidence of costochondritis. And of course, presence of elevated inflammatory markers. So your ESR and your CRP are elevated. Okay, so this becomes very important whenever you take history for a patient with suspected spondyloarthropathy. Okay, so whenever a patient presents with back pain, especially in the young, it becomes very important to differentiate whether this is a mechanical back pain or an inflammatory back pain. So these are the things that you will ask. So just to repeat, this is a inflammatory back pain is suggestive of back pain which is usually more in the early mornings, lasts for more than 30 minutes. It usually improves with exercise, and it is present in a young individual less than 40 years of age, lasts for more than 3 months, and you can have even other signs like alternating buttock pain. And whenever you do a blood test, you may find evidence of elevated inflammatory markers. Okay, so inflammatory back pain is the first and the most important clinical sign that you have to elicit. Then, if this is the only clinical features which you may find in your non-radiographic spondyloarthropathies. But in radiographic spondyloarthropathies, if you do an X-ray of the sacroiliac joint, because we know that in your ankylosing spondylosis and spondyloarthropathies, there is inflammation of the sacroiliac joint. So in a radiographic spondyloarthropathy, you find X-ray evidence also. So you might see narrowing of the sacroiliac joint, you might see bony fusion of the sacroiliac joint. Okay. So in non-radiographic SpA, often the X-ray changes are absent. So if you do an MRI STIR sequences, that is a specific type of sequence to find evidence of marrow edema. So in this you may find evidence of bone marrow edema. Okay. But if X-ray changes are present, then this is what we call as the radiographic spondyloarthropathies. Clear? So that is about your axial spondyloarthropathies. Now, in peripheral spondyloarthropathy, so what are the disorders which usually occur with peripheral spondyloarthropathy? So this does not mean that they do not have any axial involvement. So here you have peripheral along with some amount of axial involvement can be present. So which are those disorders? These are your reactive arthritis. These are your psoriatic arthritis. So we have reactive arthritis, psoriatic arthritis and IBD-associated arthritis. Okay. So reactive arthritis, psoriatic arthritis and IBD-associated arthritis usually present with peripheral spondyloarthropathy, where you can have mono or oligoarthritis. You have mono or oligoarthritis. Oligoarthritis means what? There is involvement of about 2 to 4 joints, and predominantly they are large joint involvement. So commonly you have a knee joint or an ankle joint involvement, and they can be additive in nature. So sometimes you can have an ankle joint involvement, followed by which after few days you may have knee joint involvement and so on. Okay. Another very important feature about this peripheral spondyloarthropathy is that you can have HLA-B27 positivity even in peripheral spondyloarthropathy. HLA-B27 can be positive in both axial and peripheral spondyloarthropathy, and this might be confused with a rheumatoid arthritis. Okay, especially a polyarticular type or an oligoarticular type of rheumatoid arthritis, it can be confused. But a very, very important point is that in RA, you usually have a symmetrical involvement and small joint involvement. Symmetrical and small joint involvement is found in rheumatoid arthritis, but here you have predominantly large joint involvement in your peripheral spondyloarthropathy. Very, very classical is that the RA factor or the rheumatoid factor RF is absent in peripheral SpA. Alright, then another very, very important feature which may or may not be present, but if it is present, it is more in favor of a peripheral SpA, is the presence of uveitis. Which is acute anterior asymmetric alternating uveitis. Okay, so acute anterior asymmetric alternating uveitis. Remember all these four words. So it's often an acute onset uveitis, which is predominantly an anterior uveitis, which is asymmetric and it can occur in either of the eyes. Okay, so whenever you ask about history in your patient with probably a mono or an oligoarthritis, always ask about vertebral involvement or basically back pain, which is suggestive of an inflammatory back pain, and always ask about uveitis as well. The certain other things that you will have to ask about, which we will be discussing in the later slides as well, is about history of any prior infection, because a prior GU or a GI infection can result in the formation of what we call as reactive arthritis. History of any skin lesions, because these skin lesions can precede your psoriatic arthritis. History of diarrhea, history of bloody stools, because it can be associated with an IBD-associated arthritis. Clear? So this is about the classification. So just to reiterate, spondyloarthropathies can be classified as axial as well as peripheral spondyloarthropathy. Axial spondyloarthropathy can be a non-radiographic and radiographic SpA. Okay, in peripheral spondyloarthropathies, you have your reactive arthritis, psoriatic arthritis and IBD-associated arthritis. Okay, fine. So, what is the classification criteria for the diagnosis of spondyloarthropathies? Okay, so this is what we call as the ASAS criteria. So, according to this ASAS criteria for classification of spondyloarthropathy, in patients who are less than 45 years of age, with a history suggestive of inflammatory back pain which has been going on for more than 3 months. Okay, so in these type of patients, you will do what we call as the ASAS criteria. So what are the things that we look for here? We look for evidence of sacroiliitis on imaging along with more than one SpA feature. So what do you mean by sacroiliitis on imaging? So on imaging, you see evidence of active inflammation on the MRI suggestive of the sacroiliitis, which means that when you do an MRI STIR sequence, you may find evidence of marrow edema, you might find inflammation in the SI joint, or definitive radiographic sacroiliitis according to the modified New York criteria. So what is a modified New York criteria we will be looking at? It is basically the X-ray staging for the degree of activity for a spondyloarthropathy patient. Predominantly axial, the X-ray staging in the SI joint. Okay, so if there is evidence of sacroiliitis on imaging, right, the sacroiliitis, how will you show? You will show it either on an MRI or on an X-ray. For the X-ray, the grading that we use is what we call as the New York criteria. Okay, so if there is history of inflammatory back pain and if there is evidence of sacroiliitis on imaging, then you can classify the patient as a probable axial spondyloarthropathy. Or if there is no evidence on imaging, that means it could still be a non-radiographic spondyloarthropathy. So in a non-radiographic spondyloarthropathy, either you can use a HLA-B27. If HLA-B27 is there, then you require at least 2 other SpA features. If there is definitive evidence on X-ray or MRI, you just require 1 other SpA features. What are those SpA features? Presence of inflammatory back pain, presence of uveitis, and presence of any of these symptoms is what we call as a SpA feature. So if there is evidence of sacroiliitis on imaging, you require 1 other SpA feature to classify this patient as a radiographic spondyloarthropathy. If there is no evidence of any radiographic changes, then he might probably be a non-radiographic SpA. In that case, you may require a HLA-B27 and 2 other SpA features. So what are those SpA features? So this is what we are looking at. Definitely an inflammatory back pain. So if a patient presents to you with inflammatory back pain and sacroiliitis, you can classify him as radiographic SpA. But he has only inflammatory back pain, X-ray is not showing anything. Then you do a HLA-B27, you require one other criteria. Got it? This is what it means. Then, what are the other SpA features? History of arthritis. What type of arthritis? Predominantly a peripheral arthritis, mono or oligo arthritis, additive in nature, migratory in nature. Then another SpA feature is the presence of what we call as enthesitis. So this image, what you can see here, the ankle appears full on one side as compared to the other side, correct? So what is the enthesis? Enthesis basically refers to the point at which the tendon joins the bone. Okay, so especially the Achilles tendon, once it is inflamed, the point at which the Achilles tendon joins the bone, this is what we call as the enthesis. So evidence of enthesitis, especially in the heel, is a spondyloarthropathy defining feature or a SpA feature. Then anterior uveitis, acute alternating anterior uveitis, which is asymmetric in nature, is also another important SpA feature. Then presence of dactylitis. Dactylitis is sausage digit. So one of the digits can get inflamed like this. Can you see here? Right? So this is your dactylitis. Then presence of psoriasis, presence of Crohn's disease or ulcerative colitis, good response to NSAIDs, family history of SpA, HLA-B27, elevated inflammatory markers, all of these are SpA features. Okay, so this is about your AS criteria, right? So if there is sacroiliitis in imaging, then you require one other SpA feature. You classify them as axial SpA, which is a radiographic SpA. If there is no sacroiliitis on imaging and you get HLA-B27 along with 2 other SpA features, then you classify them as your non-radiographic SpA. Then what are the other extra-articular manifestations, right? So in the eye, what will you have? Again, like I have mentioned before, you can have anterior uveitis. Then, can you have cardiovascular system involvement? Yes, you can have aortitis. Okay, very, very important point. You can have aortitis. So, whenever you think about aortitis, what are the conditions that cause aortitis? Yes, we know there is syphilis which causes aortitis. Then, apart from syphilis, where else do you find aortitis? You can find aortitis in which forms of vasculitis? Predominantly Takayasu arthritis, right? So all of these can cause aortitis. Also, you can find it in IgG4 related diseases. So these are the other condition where you can find aortitis. Then along with the aortitis, you can have aortic regurgitation. So which valvular heart disease is associated with your spondyloarthropathies? It is aortic regurgitation. Then in renal, in the kidneys, you can have secondary IgA nephropathy. Then in the lungs, can you have ILD? Yes, the answer is yes. You have a predominant upper lobe NSIP ILD. Okay. So in our interstitial lung disease classes, we have learned what is UIP, what is NSIP. We know that NSIP is the most common pattern of ILD seen in most of the rheumatological disorders, and hence even in ankylosing spondylosis or your spondyloarthropathies, you get an NSIP pattern predominantly involving the upper lobes. Then in the bones, you can have osteoporosis. So these are the various other extra-articular manifestations which can be seen in spondyloarthropathies. Now let us look at the radiological signs more in detail. So we had briefly discussed about the New York staging, right? So New York staging basically refers to the X-ray staging in the SI joint, right? So the moment you have some amount of SI joint involvement along with inflammatory back pain, predominantly if it is a symmetrical involvement, SI joint involvement, then it is more in favor of what? More in favor of axial SpA, or what we used to call as ankylosing spondylosis. Clear? So that is about your New York staging. So what are the stages? So grade 0. In grade 0, you can see that the joint space is still preserved. There is very, very mild haziness in the joint, right? Then in your grade 1, you can see that there is narrowing of the joint space. So, there can be narrowing of the joint space. Alright. Then in grade 2, what happens is that there is fluffy inflammation. You can see fluffy inflammation and the joint space is completely narrowed. Then in grade 3, you have something called as pseudo widening. And grade 4, you can see that there is no space at all. And this is what we call as complete bony ankylosis. Okay. So this is what we call as the New York staging or the different X-ray findings you can grade in your axial spondyloarthropathy. Right. Now, so first X-ray finding is your symmetrical SI joint involvement, SI joint inflammation, sacroiliac joint inflammation. So this is the first finding. Secondly, you can have what? You can have inflammation in. So if these are your vertebrae, the vertebrae can become squared out. So you can have squaring of the vertebrae. You can have squaring of the vertebrae. Also, you can have inflammation of the disc. You can have inflammation of the disc and you can have something called as syndesmophyte formation. So you can have something called as syndesmophyte formation and these are usually marginal syndesmophytes. Okay, so there is formation of marginal syndesmophytes. There is inflammation of the disc between the two vertebrae and ultimately the vertebrae gets fused. Okay, so certain other radiological signs that we should be aware of, right? So what is bamboo vertebrae? So once these vertebrae become squared out, they appear very similar to the bamboo shoot and this is what we call as the bamboo spine, which is the last or the almost last stage of ankylosing spondylosis. Then, so we have an interspinous ligament which is running here, right? So we have an interspinous ligament which is running here. The interspinous ligament can get calcified and the sign that you get is what we call as the dagger sign. Also in the vertebrae, once they get fused because of the bridging syndesmophytes which we find here, and the joint capsules on either sides can also get inflamed and they fuse together, and this is what we call as the railroad sign, right? So the apophyseal joint capsules can also get calcified and inflamed and this is what we call as the railroad sign. And if you have both the dagger sign and the railroad sign together like this, so we have the dagger sign as well as the railroad sign together, this is what we call as the trolley track sign. Okay, so this is about the different named signs which you can find in the X-ray of an ankylosing spondylosis patient. Then you have something called as the Romanos sign. So each of these vertebrae can undergo chipping and in the corners you can get opacification. So this is what we call as the Romanos sign. So these are about the various radiological findings which you can find in a patient predominantly with axial SpA or your ankylosing spondylosis. Now, in the MRI, can you notice here? In the MRI, you see that there is evidence of marrow edema. There is evidence of marrow edema, right? You can see evidence of marrow edema in the MRI images. So this is showing you nothing but the same images. So there is evidence of bony ankylosis here. Also, you can see evidence in these images. You can see that there is inflammation, especially in the corners, that we call as the Romanos sign. Okay, and this is showing your complete ankylosis of the spine. So this is about the different radiological features which you can find in spondyloarthropathies. So a clinical test which can be used for the diagnosis of your ankylosing spondylosis is what we call as the modified Schober's test. Okay, so in this modified Schober's test, what do we do? So we basically take the PSIS as the points. The PSIS is your landmark and you basically take a point which is 10 centimeters above and 5 centimeters below the PSIS. Okay, so these measurements are taken when the patient is standing upright. Then you ask the patient to bend forward, and the distance between these 2 points, the distance between point A, which is 10 centimeters above, and point B, which is 5 centimeters below the PSIS, this distance should increase to more than 20 centimeters. But if this does not increase to more than 20 centimeters, that means that there is a restriction of movement, and this points more towards an ankylosing spondylosis. Clear? So this is about your modified Schober's test. Fine. Now, how do you manage a patient of ankylosing spondylosis? Right? So first is pain management. So the first line treatment in the management of ankylosing spondylosis is to give NSAIDs, which can be given prolonged for up to 2 to 3 weeks. Okay, if there is no improvement and there is still ongoing inflammation, then anti-TNF agents like adalimumab and anti-interleukin 17 like secukinumab are the other drugs which can be used. Alright. Also remember that these patients over time, if they progress, they can also have a restrictive lung disease. They can have an ILD, and they can have type 2 respiratory failure because of the restrictive lung disease. Hence, it becomes very, very important that you try and manage these patients earlier on. So that is about your axial spondyloarthropathy. Now let us go on to the next type of spondyloarthropathy, which is reactive arthritis. Reactive arthritis is predominantly peripheral spondyloarthropathy. This is more common in males than females, and it is seen in the 20 to 40 years age group. Okay, so most of the connective tissue disorders are more common in females. The only group of connective tissue disorders which you can easily remember as males more than females is this spondyloarthropathy group. So most often reactive arthritis is secondary to an infectious trigger. Okay, so amongst the genitourinary triggers, it is a GU infection, it is chlamydia. Amongst the GI infection, it is Shigella more than Salmonella. So whenever we speak about reactive arthritis or any form of arthritis, always ask about history of a preceding GU or a GI infection. Okay, so if followed by this infection, usually around 2 weeks later, you can have development of an arthritis, and this is usually a mono or an oligo arthritis. Okay, and this arthritis is often a sterile type of arthritis. So if you take a joint aspiration and send it probably for a culture or a gram stain, you will not find evidence of any organisms. But these organisms go and lodge themselves in the synovites or the synovial cells. Okay, so these organisms go and lodge themselves within the cells of the synovium, within the synovial cells. And hence, if you do a PCR on the joint fluid, so if you do a PCR on the joint fluid, you may find evidence of these organisms. Clear? What type of arthritis you get? You get an asymmetrical oligoarthritis, and it is additive in nature. So you may have one joint inflammation that may settle down, it goes to the next joint, and so on. Of course, there is evidence of dactylitis, and you can have certain mucocutaneous manifestations as well in reactive arthritis. So what are the mucocutaneous manifestations? You may find evidence of ulcers. These ulcers can be painless. Okay. Then on the skin, especially around the genitalia, you may find evidence of what we call as keratoderma blennoragicum and evidence of circinate balanitis. Okay. So what is circinate balanitis? In the penile region, you may find evidence of these circle lesions which are often painless. Okay, so this is about your Reiter syndrome. And when we speak about the axial involvement, yes, you can have axial involvement, and remember this is asymmetric in nature. Very, very important point. The axial involvement here is asymmetric. So you may have unilateral evidence of SI joint inflammation. So there is an asymmetric axial involvement in comparison to your ankylosing spondylosis. Yes, so this is about reactive arthritis. So how do you treat your reactive arthritis? So treatment predominantly involves NSAIDs, similar to how you treat your ankylosing spondylosis. If there is no improvement with NSAIDs, then you can give intra-articular glucocorticoid injections. You can use intra-articular glucocorticoid injections. You can also start them on sulfasalazine. Okay, right? So this is about your reactive arthritis. The next type of peripheral spondyloarthropathy is the enteropathic arthritis, or what we call as the IBD related arthritis. Okay, now this IBD related arthritis is more common in Crohn's disease than in ulcerative colitis. This also can have axial involvement, and here it is a symmetric sacroiliitis, right? So asymmetric is reactive arthritis. Here you can have symmetric sacroiliitis. But what type of syndesmophytes do you find? You can find evidence of non-marginal syndesmophytes. Non-marginal syndesmophytes. And most of the time, IBD-associated arthritis may or may not have association with the ongoing bowel activity. Okay, so the peripheral arthritis in SpA, so you can have axial involvement, but you can have predominantly peripheral involvement also in IBD-associated arthritis. So the peripheral type can be classified into type 1 and type 2. So the IBD-associated arthritis of the peripheral type can be classified as type 1 and type 2. What are the differences between your type 1 and type 2 IBD-associated arthritis? Type 1 is predominantly large joint involvement, it is migratory in nature, and it is a type of oligoarthritis, whereas type 2 is predominantly small joint, symmetric, additive in nature. Okay, so type 1 is asymmetric, type 2 is symmetric, and it involves a small joint. So type 2 is very similar to rheumatoid arthritis. Okay, whereas type 1 is predominantly asymmetric, oligoarticular, migratory, and large joint in nature. But here it is symmetric, small joint, and additive in nature, and it is polyarticular. Okay, so what do you mean by migratory versus additive? So migratory means that, let us say that this is your ankle. So you have ankle involvement here. Now after the ankle joint swelling subsides, so this swelling subsides, then only you can have knee involvement, right? So there can be inflammation of the ankle that subsides, and then you have knee involvement. So that is your type 1 peripheral arthritis. But in type 2, what you have is additive in nature. That means that if your small joints are involved here, together you can have multiple joint involved. Okay. So type 1 correlates with IBD activity, but type 2 does not correlate. So type 2 arthritis can occur independent of the bowel activity. That means that the patient may be in remission in terms of his Crohn's disease or ulcerative colitis, but he may still be having joint flares. And an additional feature that you find in type 2 is its association with uveitis, which is not found in your type 1 arthritis. Okay, type 1 arthritis has good prognosis and it is self-limiting, whereas type 2 arthritis requires treatment and you require the presence of TNF-alpha agents for the management of type 2 arthritis. Okay, so this is about your type 1 and type 2 IBD-associated arthritis. Okay, now let's move on to the next type of spondyloarthropathy, which is your psoriatic arthritis. Okay, so psoriatic arthritis is also seen in both males and females in a ratio of 1:1, whereas all the other arthritis were more common in males, and it is seen in age group more than 40 years of age. What are the associations or the risk factors for the development of psoriatic arthritis? HLA-CW, HLA-B57 positivity can also be there. So what are the clinical features? The clinical features is that you can have arthritis. Again, it is usually a peripheral type of arthritis, and it can be a mono or oligo-articular. If there is axial involvement, again it is asymmetric axial involvement, unlike the symmetric axial involvement which you find in spondyloarthropathies. You can have evidence of Dactylitis, Enthesitis, and the Uveitis that you see here is again very different, important highlighting feature. It is a bilateral chronic posterior uveitis. So the highlighting words is chronic because acute is seen in ankylosing spondylosis. Anterior uveitis is seen in your axial SpA. Here you find chronic and you find posterior uveitis. So very, very important differentiating features. Okay, fine. And what is the classification criteria which we use in psoriatic arthritis? It is called as the Caspar criteria. Even if you don't remember everything, try and remember this name. Where do you see Caspar criteria? It is psoriatic arthritis. So there is evidence of current psoriasis or personal history of psoriasis or family history of psoriasis. So that is one criteria. There is a typical psoriatic nail dystrophy. What do you find in the psoriatic nail changes? You may find pitting. Okay. You may find onycholysis. Onycholysis means the nails are getting destroyed. You can find your salmon patch. You can find oil droplet appearance. So these kind of nail dystrophies, if it is present, it is a criteria. Okay. Then negative test for RF, very, very important. Then current dactylitis or history of dactylitis and radiographic evidence of juxta-articular new bone formation in the hand or foot. Okay. So if the patient has more than 3 points from any of these 5 points, this is what we call as Caspar criteria for the classification of psoriatic arthritis. Okay, fine. So these are the important points, and remember chronic posterior uveitis as a differentiating feature. Psoriatic arthritis can present in different forms. Okay, so it is not always your peripheral spondyloarthropathy. So there is a classification which is used to describe the different types or patterns of joint involvement in psoriatic arthritis, and that is called as the Mole and Wright classification. So according to this Mole and Wright classification, what are the different forms in which psoriatic arthritis can present? So this can be of the symmetric polyarthritis type, which is the most common type, symmetric polyarthritis. So this is very, very similar to your rheumatoid arthritis, but is this in the presence of a negative RF. Okay, so this is very similar to your rheumatoid arthritis in the presence of a negative RF, and it can be associated with skin lesions. Then you can have an asymmetric oligoarthritis type, and very, very important, predominant distal interphalangeal joint involvement. That is the characteristic features which helps in differentiating from rheumatoid arthritis, because rheumatoid arthritis does not involve the DIP, but in psoriatic arthritis you can have DIP involvement. Okay, so the first is the symmetric polyarthritis type, second is your asymmetric oligoarthritis type, then third is your predominant DIP involvement, fourth is your predominant only spondyloarthritis, so very, very similar to your axial SpA. Then fifth variant is arthritis mutilans. Arthritis mutilans, where all the joints can be involved and there is complete destruction of the distal interphalangeal joint. Okay, and remember all of these can be associated with either skin or nail changes. So there can be evidence of either skin or nail involvement. Remember, the most common type is a symmetric polyarthritis, similar to your rheumatoid arthritis. Okay, so these images are basically showing you what are the patterns. So this image is showing you your psoriatic nail dystrophy. Now, can you see here in these two images that there is a predominant distal interphalangeal joint involvement like this, right? So this is what we call as the pencil in cup deformity. Pencil in cup deformity, which is a characteristic feature of psoriatic arthritis. Apart from that, in some patients with psoriasis, you can have involvement of all the 3 interphalangeal joints, okay, like this, okay. So this is what we call as the ray-like appearance in psoriatic arthritis. Fine. So that is about the different patterns that you can find in psoriatic arthritis. So what is the treatment of psoriatic arthritis? Here, PDE4 inhibitors, the drug that we should be knowing is apremilast. So apremilast can be used. Then other inhibitors include ustekinumab and secukinumab, which are other drugs which can be used. This is anti-interleukin 17. S for S, anti-interleukin 17. Secukinumab is the other drug which can be used in the management of psoriatic arthritis. Okay, so with this we have come to the end of our discussion on spondyloarthropathies. Okay, so what I want you to take away from this class is, what is spondyloarthropathy? The newer classification as axial and peripheral. Under peripheral, what are the diseases that come under that? And then axial SpA can be classified as radiographic and non-radiographic SpA. And what is good to know is about the different X-ray signs. And of course, you should know how to differentiate each of these types of arthritis. Thank you.